The Philippines is a nice place to live and work, but if you are living and working there, it's important to buy a good health insurance plan. There are some good medical facilities in the Philippines, but getting access to them, and particularly getting evacuated to those facilities if you happen to be injured in an accident or through illness in another part of the Philippines, is important. As such, we recommend you buy a good quality health insurance plan. Most health insurers today will break down a plan into a modular form. It will have an inpatient component and an outpatient component, which covers things such as doctor's visits, medication, diagnostic tests. There may be the option to add on maternity. You may have the option to add on dental or vision. Perhaps pre-existing conditions can be covered. So today, when you're looking to buy a health insurance plan, part of the process we help you go through is to look at different modules that can be offered by different insurers and design and build a plan that's right for you. Beyond that, it's also important to recognize that perhaps some medical treatment is not available in the Philippines. So having a policy which allows you to be covered in perhaps Hong Kong or Singapore, including perhaps the evacuation to one of those countries, may also be important to you. So if you're living and working in the Philippines and you're looking for a good quality health insurance plan, then please come and talk to us and we'd be happy to help and advise you.
I thought we'd jump right in because it's such a great panel. You rarely get such a dynamic panel. We've got two fabulous professors at Penn who are studying healthcare markets. We've got a very dynamic and visionary exchange leader, and then we've got the CEO of Avalier, which, Dan, I don't say that as a joking way, but I'm not sure how to fit you in, but you provide an amazing perspective from the private sector, all the research you're doing. I'm going to start by calling on, we've got John Kolstad and Amanda Stark from Penn, our professors here, and asking them to talk about what we know about consumer choice and what we're seeing so far in exchange markets.
One thing that we've seen in our research is that consumers are not necessarily sitting there with a fancy Excel spreadsheet working through their expected claims over the course of the next year, thinking about how risk averse they are and picking the optimal plan based on those factors. Instead, what we see is that they might either rely on rules of thumb or be cued by certain features of the environment as to what to focus on. So in one study, we look at just how many consumers choose the cheapest plan available. This is in Massachusetts, and these are unsubsidized consumers, so you don't have to worry about subsidies here. The cheapest plan during our time period that we're looking at is going to be listed first on the website. And when I put the screenshot up for my undergrads and ask them what they would pick, they immediately say the cheapest plan. So we have some nice features to the market where the cheapest plan is going to vary in different parts of the state for different people. And what we observe is that about 20% of people just gravitate towards that cheapest plan over and above what we would predict based on what we think their underlying preferences are. What we then saw in a later time period is that Massachusetts standardized the set of options that were available to consumers along their financial dimensions, while they were still allowed to vary by network. And this is going to change the way the website looks. And so by changing the way the website looks, you might provide different information to consumers, but you might also focus their attention on different features of plans. And what we observed in that study is that consumers were more likely to pick more generous plans, and they put less weight on things like brand. So going forward, I think it's important to think about how we present information to consumers and how that might guide them towards one type of plan over another.
The actual choice process, to really understand kind of how well, in quotes here, that requires some assumptions or understanding, but there's actually a real strong data requirement and there's dynamics. So I think that's an issue that one wants to learn from other experiences first rather than sort of jumping to just year one without knowing actually how much people, what their claims were, you need to understand risk aversion and risk and things like that, which is very hard with the data environment. So that in mind, I think we can learn a little bit from other kinds of choice experiences, and in some sense that may not even look the same, in fact may maybe be even easier. And so at that work, we basically studied a very simple choice. It was just a high deductible plan and a PPO plan. The only distinction is financial. So we've basically made it as simple as possible. One of the relatively unique features of that study is we actually surveyed people to understand what they could tell us about that choice and then linked it to their actual claim. So you could understand what they knew as well as ultimately what choices they made. And the results we found, and this is an extremely unrepresentative firm, very highly educated, very high income, simple choice. So we're starting where we think we might not find challenges. And in fact, we do find very large rates of lack of understanding of what a deductible is, what the level of that deductible is, what coinsurance is, what an out-of-pocket maximum is, which are all relevant to making appropriate decisions, certainly even in a simple case, let alone in a variety of plan options. Even there, there's actually no network distinction, yet a minority of people could actually identify that the network was or wasn't the same. So this uncertainty is rife in this situation, and what we actually find, two things which I think are relevant. A, that has a very, very large impact on choices, and very importantly, it has a very large impact on switching plans. And so it seems to be lack of information is highly correlated with switching, and that has, I think, two effects. One is that things that happen early on in an exchange's life can be very long-lived if you don't have the associated decision support or helping people actually work through these information frictions, right? So if small decisions today might be with us for a long time if people aren't moving out of those plans. You've also seen that in Medicare Part D over time, right? That there's very high switching costs in that environment. The other thing that you get there is that it's hard to recover what people want from their choices when they're not very well informed. And I think that's going to be important because in some sense exchanges are not just they are market makers. They're not just kind of an environment to go and choose. And there's going to be a role, particularly as these marketplaces mature, in understanding kind of what menu of options people might want. And what we show there is if you go on, think of as economists, you think of revealed preference. People seem to really like this plan. That can be misleading because if you have a lot of people who weren't very informed and they may just ask the person next to them, you're going to have these sort of herds that may not end up in the right plan. So there's an important role and a balance to try to actually get to the bottom of preferences amongst informed consumers. And I think that's something that underscores, again, even in an employer-based, relatively simple, very simple and very highly educated environment. The other effects I think that we've seen again in Massachusetts is this role of potentially important role of market maker from the research. And so in some work with Amanda Kowalski, who's at Yale, which was also funded by RWJ, we looked at the impact of the overall health reform, but in particular the role of the exchange in impacting adverse selection and price competition. And there you find that in fact both effects were very important. So welfare was improved substantially in the individual market. We saw, relative to trend, premiums were reduced by 24% in the individual market in Massachusetts. The average cost of those enrolled went down by 10%. So there's both effects that adverse selection is being reduced. We're bringing healthier people into the pool, but there seems to also be this important role for basically more competition or different competition. And I think that underscores, again, the role of exchanges, not just for those individuals on the exchange, but in general in determining what's available and how plans generally compete and how the market functions on that front.
Two pieces of research I'll just highlight from work that we've done. First is on the consumer choice issues. We did a lot of, if you will, kind of more market-oriented research prior to the exchanges coming online because, of course, all of the insurers want to anticipate how consumers are actually going to select when they get online. And a couple of interesting things. First, most people didn't even look past the premium. So if you think about a benefit design that has a premium, a deductible, and then very typically high out-of-pocket costs for drugs, which are additional, in some cases actually an additional deductible that is only applicable to drugs. Just looking at the premium is an error. And what we found was that many consumers would actually go on and do that, which of course drives premiums down. That's a good thing. I mean, you want to kind of drive premiums down, but yet I think it kind of raises questions. And in some markets as well, we saw that consumers didn't actually know what a deductible was. And they also didn't understand that when they got to the pharmacy, they would have to pay an additional copay. So there's a lot of very basic education that I think is important that needs to be done. We did a study of oral oncolytics. These are cancer drugs that are taken by mouth. They are not prescribed casually, and we compared, and this was using a claims database of a very broad group of people, young, old, and we looked at these oral oncolytics and what the abandonment rate was likely to be at the point of sale, so at the pharmacy. So the patient goes, and they're going to face a copay for their drug. What is the probability that the patient abandons that medication at the point of sale? And we found that there was about a 6% abandonment rate if you had a copay under $100, and if you had a copay above $500, there was about a 24% abandonment rate of the medication. And it's just something to think about, So what happens to that patient? And these drugs are not prescribed casually, so we chose the class, on purpose, if you will, as a class that is likely. And when you go online to look at these exchange designs, virtually all of them have a specialty tier where they'll take biologics, specialty drugs, any drug that costs more than $500 in many cases, and put that onto the fourth tier. So I do think it becomes important for all of us to be thinking about what happens to those patients.
Yeah, and I'd just add to that so far a lot of what we've emphasized is the financial features of the plans, and that's certainly important, but obviously networks are critically important as well. And so in some preliminary work, we've looked at networks, and it seems like consumers don't necessarily value networks like we think they should. Like they focus on certain things like, is a key hospital a network, as opposed to a measure of the broad network overall. And I would also highlight that this has important consequences if we're thinking about how insurers are thinking about designing plans, and that might lead to more limited network plans going forward.
I'd add just two things. First, the decisions that are made by the exchanges will affect the insurance company behavior very profoundly. And I think one of the things that we saw when the act was passed and the Medicare Advantage star ratings became a basis of payment was that all of a sudden all the Medicare Advantage plans started to invest very heavily in trying to improve their quality ratings. And part of that was this big red screen that would come up if a consumer went on and tried to enroll in a plan that had, I think, 2 or fewer stars. I can't remember the cutoff, but that must have had an effect. I mean, we didn't study it, but you kind of log onto the Medicare site, and all of a sudden this red screen comes up and says, "This is a low-quality plan." And we don't have anything like that in the exchanges, at least that I'm aware of. And I think that that is something that we need to be thinking about. How do you get some of that information to consumers, even if it's imperfect? The second thing is that some of the consumer choice models that we were talking about before really do affect the strategy that a health plan will take in actually approaching a market. And if you know that you are going to attract a large number of relatively sick patients, it's going to affect your underwriting, it's going to affect your pricing, it affects everything. And it's something that we have to be very conscious of. I think that the risk adjustment that is layered into the way this construct works, in my view, is inadequate and needs to be revisited. And it is something that ultimately, you want to give a health plan a really strong incentive to have an outstanding network for cancer patients or for MS patients or for, kind of the sickest of the sick. And I don't think we have that yet. And I think it's kind of borne out when you look at the network. So we studied whether the major cancer centers were included in health exchange networks nationally, and found that generally they're not. And if you think about it from a signaling perspective, why would you want to try to attract all of the patients with the most complex cancers into your network at this point in time, unless you thought that it was economically advantageous? And at this point, it's really not. So every one of these decisions that is about consumer choice also affects the market in a construct like this.
So you mentioned Medicare, and John, earlier you'd mentioned some Part D lessons about high switching costs, and we're about to go into renewals season. So consumers are going to decide whether or not to keep their same plan or to switch. And so can you say more about those lessons from Part D?
Yeah, I think that, and these lessons come together a lot in the sense that this is a great opportunity to get competition to do what we think it should do, which is provide innovative, lower cost products to everyone and reward the firms that are, providing that. And in some sense, you think that more plans is better in that view, but you have seen, particularly in Part D, which has been the most studied because it's a little bit simpler to study in the sense that you just have to deal with drugs, though there is some evidence on very similar effects and advantage that you have similar numbers if we're talking about the individual market in DC. You have that 30 plus plan range is what we're talking about. There seems to be a lot of choice errors being made. The average person is leaving just in Part D alone $450 a year on the table, and that's the average. I mean, it's very, very skewed. And you have great evidence for this heavy overweighting on premiums relative to other costs. And there's growing evidence that not only does this impact, the pocketbook at the end of the day, but that relates to actually adhering to the drugs going forward. And so these things, they're not trivial financially. They're not trivial from a health perspective.
I'd just add from the Part D context, like simple interventions can have a big impact. So just sending someone a letter that says, hey, you're in Part D, you might want to look and make sure this is the optimal plan again this year. So I think a lot of what we're talking about is complicated, but even simple interventions can have a big effect.
So do you have thoughts about renewals and about the federal approach, which is it seems to be two tracks: encourage people to shop because we want people to shop and there may be better choices for them, but have a default of auto renewal so that you don't lose people?
And I think there's a real tension there.
Mm-hmm.
You don't want people falling off at the end of the year. But at the same time, if we're trying to leverage all the benefits that we economists think there is to competition, then that's really going to rely on effective consumer choice and consumers who are paying attention to the set of options that are available and who are making choices that reflect what we think their underlying preferences are.
I would add, I think there's opportunity here for smarter defaults. So the defaults have tended to be pretty one-size-fits-all. And if you look at the low-income subsidy plans on Part D, there is a right plan for people if you know what drugs they're on, yet we're sort of randomly defaulting them. And so I think there's an opportunity here to make smarter defaults if you're going to use that, so that you basically start with that point, you nudge them in that direction, and then if they want to move away, you both facilitated the shop, but if they don't, then you've at least said, well, this is our best crack at it, which is much better than random, which tends to be the way defaults are allocated out in a lot of different exchange type environments.
Well, Mila, when you think about exchanges 2.0 and 3.0, and when you get into the out years, do you have thoughts about how you can improve the defaults for consumers?
Yes. If I can just share with you what we saw during the first open enrollment. We saw a very small percentage of our new customers make switches during the first open enrollment, and it was a lot of, I thought I was getting an HMO and this is a PPO, or vice versa. So we did see a little bit of that once people started to perhaps use their insurance for the first time. In planning the renewals for this cycle, we're assuming that most people will not be doing anything. So our approach is to assume passive renewals. So everyone will get a letter saying, please come shop November 15th. Great choices, new options, more affordable options in some cases. But if you do nothing, you'll automatically be renewed into what you have now.
How do you design these systems so that they will actually work commercially and also do the right thing for consumers? So some of these, some of the kind of the smart designs, and even back when I was in the administration before, in the Clinton administration before Part D was enacted, and we were trying to design a lot of these things, they have implications. The design decisions have implications about whether the markets are going to be viable for insurance companies. And so if you actually use algorithms to channel people into the quote-unquote right plan for them, that affects underwriting. And I think one of the reasons why we don't have that now is because it will tend to channel patients into the plans that are the most generous for the sickest patients. And you need to design these things in such a way that there is an incentive for insurance companies to have designs that are generous, and the kind of the selective auto enrollment has disincentives to more generous design by and large. So it's hard, and sometimes you face these design decisions where the interests of the consumer might not ultimately result in a viable product for the insurance companies.
So Dan, let me stick with you. That's a great segue. We wanted to explore how these public exchanges are impacting the broader insurance market.
What's happening now is that, of course, what employers want is to pay less and over time to navigate more towards these less generous designs. And what we are starting to see with a little bit of research, and it's an area that I think we're really going to be focusing on over the next year. We're starting to see these same designs, these exchange designs, now coming into the private sector, because if as an employer you don't want to drop, because that might be too precipitous, if you will, but you really do want to get your costs under control. And if the federal government has already given its imprimatur to these designs, why not try to avail yourself of them? And that's something, again, that we're starting to see in some markets, but we will be certainly studying. I think that one of the things that is also affecting these markets is that from a competitive standpoint, why do you really care about the exchanges? Like right now, it's 2-3% of the market, so 8 million people, and the answer is that we expect it to grow, and that it is also being fielded relative to all these other products. So that if let's say you go out and you negotiate very aggressive provider networks, or you kind of move into a more integrated world, then you're essentially setting yourself up to be able to use those same networks and tools in other products. And what we see kind of from a strategy perspective with most of the insurers, whether they be Blues or some of the larger ones, is that you want to be a more dominant player in a market. And generally what that means is having a broad set of offerings across that market. So you want to have commercial, you want to have Medicare, you want to have Medicaid, you want to have exchange. So if you have really all of them, then you get more of a return from investing in visibility, and then you also are able to kind of leverage those strengths across all of the different markets. So those are a few things that we're seeing in our research.
I would agree, and I wanted to sort of in the broader scheme of how the exchange interacts with the broader insurance markets and even other markets around it, right? This is fundamental to things like employment. And there's some interesting dynamics there where we basically found that in Massachusetts, after the individual mandate, you actually saw an increase in the offering of insurance by small employers. And this, basically it makes sense if you think about people wanting insurance. Once you've been given a mandate, a job with insurance becomes that much more valuable to you. And in fact, we saw that there was no impact on employment, but basically people just were compensating the wages with the cost of that insurance almost exactly. And this underscores that's one specific situation, but what's offered on the exchange relative to what employment options you might have is going to be important, not just in the insurance market function, but in particularly how small businesses and individuals seek employment. And I think that's something that there needs to be more study of and understanding of as we go forward.
In studying Massachusetts, which we did also we're constantly calibrating this, you really did see that there was limited dropping of coverage, and that really informed our projections that we did not expect to see massive dropping of coverage. And what we're seeing now is that while there is some dropping, most employers don't want to drop. And then the other thing that's happening is that the products that they are being offered, as I was saying before, are changing. So they're being offered more narrow designs. They're being offered, some of these innovations that are coming through the exchange designs. And so, this idea that all of a sudden we're going to see everything fall apart and there's going to be no more employer coverage, I think, at this point really doesn't look like it's bearing out.
Yeah, I'd just add to that, this points out that insurance is not this monolithic one policy. There's a lot of variation, and consumers might have really different preferences over those different variations, and the exchanges might provide a nice opportunity to learn about what consumer demand actually looks like once you give them more than, one or two choices.
I want to get to our third theme, which is this. We've got Hill staff, a lot of interested observers in the audience. What would we like if, in a perfect world, where normally a large statute like the ACA would come back to Congress and would be tweaked and revised over time, we would, so assuming that perfect world where you could do that, what would we like to tweak? And maybe I'll start with you, Dan, because you have experience, obviously, in the administration, so you've seen legislation go through that kind of review, but also you teed up earlier, you mentioned risk adjustment, that you thought risk adjustment is not at the right level in the law.
So with that, the risk adjustment I think is a big issue, something that needs to be both studied and calibrated, and really what underlies that is what is the experience for patients who are sick and who have high expense, and how do you encourage more innovative benefit designs that will enable insurance companies to be responsive to those needs and not subvert their market. So that to me is probably the biggest one that should be collaborative. It requires attention and the like. I'll add one other that is perhaps a little bit controversial, which is kind of authentication and fraud control. In order to succeed, every public program has to aggressively get after kind of who's eligible, whether they're really eligible for the benefit, whether there's, they're all of these fraud elements. This legislation is really light relative to Medicare and other. And there was a reluctance, I think, to put in heavy authentication because there was a lot of concern about enrollment, and you don't want to deter enrollment. But having said that, kind of on a going forward basis, I do think that it is important to layer more of that in over time so that the kind of the program integrity aspects are being taken care of.
I think on the exchange side, there's a few quick things. I think one, and this relates to the fraud or validation question, is actually the converse of that, which is this churning across both subsidy barriers and the Medicaid barrier. I think we haven't seen that issue yet, but it's a challenge and it's a trade-off, right? That's exactly the kinds of things you need with fraud. And I think understanding and being able to coordinate that better, which is it requires tweaking in a big way, is important.
So the affordability piece is really critical. So for our consumers, we really would like legislative attention to how we can ensure more people who are still struggling with affordability. The other aspect, or the other element on my wish list, is focusing on SHOP, which is the marketplace for small businesses. The law has some prohibitions on what kind of products we can offer to small businesses, in addition to offering qualified health plans and qualified dental plans. So if you know the small business community, you know that employers like to offer other benefits like disability, short-term, long-term disability, for example. So I would like some more flexibility around the products that we can offer to small businesses, and frankly, individuals as well who'd like the one-stop shopping, one bill from us for everything.
And that would help you with sustainability as well, right?
Correct. And then I'll just put on my wish list, it's more of an observation on what's happening in some of the other states. Rate review has, I would say, is even more important. My wish list includes real backup authority for the federal government to actually do rate review and say no when it's appropriate on rate hikes.
We're going to take a short break, but please join me in thanking a terrific panel.